Okay, here we are with no listeners. So all of you out there, welcome to the Sunday video podcast. And we're doing this on my personal Facebook page rather than my public one, so some of you may be confused for that reason. And so if people don't start coming on, maybe we should turn it off and go over to the other one. What do you think? Oh, here's somebody, Baba, yeah. Hi, Baba. Hi, Linda. Hi, Hilda. Hi, Dilset. And Lisa Taylor Wade. We were hoping you would be here, Lisa. All 5 of you so far. Well, goodness gracious. Usually I publish these on my public Facebook page, and unfortunately we couldn't get that working. It was so complicated with all kinds of high-tech instructions rather than just click and shoot. So we came over here. So maybe we'll just do our best, and hopefully people can download this later on. Have a little call to action here. It's Sunday. What's the date? It's December 3rd. Wow. We had our Sunday hike, and now stuff is floating across the screen. That looks better. And we had our biggest one ever, like 16 or 18 people. I thought it would be a small one because a lot of people canceled due to the annual holiday party at Jill Levitt's home for all the team people in our training program. But a ton of people showed up, and we had a lot of fun, and we worked on relationship problems, on the inner and outer dialogue, what you say to yourself that gets you all fired up and angry and feeling frustrated and inadequate and hopeless when you're arguing with someone. And we also did the external solution, not only changing the inner dialogue, but changing the way you communicate and think about the relationship conflict. So it was very rewarding. We went for about 7 miles, and we did what was, for me, some pretty stiff stuff. Do you want, is there some severe hikes? Oh, and here on Facebook, there's Ron Alberg. Yes, it is on, Ron, but I don't know if you're on. Ron Alberg.
Let's just keep on going. We're going to fumble through this, David.
Yeah. Okay. So that's just something I can't answer him there, or?
Don't go on there. Go back where you were.
I'll just say, how would I say yes here?
Yes.
Where?
Just right down here. Yes. Right there.
Yes.
Stay on that other video.
Okay. Yes, on my personal Facebook page today. Okay, and now we're going to go back over to here. So hopefully Ron Alberg can join us over on this page. And do you want to say a few words here? And then I have a couple questions to prime the pump. But if you folks have questions, and John, you're very welcome. Type in your questions, because that's what gets me fired up. I printed a few that I got in email format, but I'm going to introduce Lisa Kelly. Lisa's kind of the brains and inspiration and energy behind a lot of this outreach that I've been trying to work through social media. Tyann isn't on either.
No, she's having dinner with her family.
Oh, okay. Lisa's been doing a brilliant and heroic job. My knowledge of social media is extremely primitive and naive, but she's been kind of helping out a lot. And so I'm going to give her this. We're not set up for 2 people to dialogue and role play yet. I hope we can develop that so a guest on this broadcast can be more like a real guest. But at least you have a chance to say hello here to Lisa.
Okay, I feel like I'm on NBC News, David, co-hosting
2016. I'm Lisa Kelly. I'm from Denver, Colorado, and I am one of David's very loyal followers. I read his book in, 1991, and it changed my life. And I just really devoted myself to cognitive behavioral therapy as a therapist. And I decided one day, hey, I'm going to make him continue to be famous and even more famous. So, and I'm a former journalist, so I have some idea of how the process works. But I just wanted to thank David very much for having me here today. Flew in especially for Jill Levitt's holiday party at her home, the Feeling Good party. And we're going to have about 90 people from Feeling Good tonight, and that's just local. So just wanted to spin here for just a second. I'll start with David. Wow, David, there's tremendous progress to report on everything you've done in the last couple of years. But I'll just start with this year. I stay in an almost constant state of hypomania, trying to keep up with you.
I was one that tried to keep up with you, Lisa.
No, I mean, it's back and forth. But David and I are on the computer every day, several times a day, and we also are working with Tyann Trong and the people at the Feeling Good Institute, which is headed up by Moore Katz, Dr. Moore Katz, who was the brains behind that organization. But I've been all over this United States, it seems, following David and trying to keep up with him. First in New York, actually New Jersey. So he went to Virginia, then he went to New Jersey, and then he went to Philadelphia. And then just recently, oh my gosh, you were in, let's see. Raleigh, Atlanta, and Denver. And then after that, you were in Canada. And then most recently, you've been in Canada. But you were at you're going to some more conferences as well. And you're a prolific writer.
In San Diego.
San Diego, that's right. So when he's not traveling, David is publishing, writing, answering emails. He is a very energetic person for sure. So I just want to say thank you, David. It's great being your colleague, and I just don't know, what I would do without your help in getting the word out.
Okay, well, I have some more stuff to report.
Oh, okay.
Other good news on the Sunday broadcast, we're getting, I think, roughly 1,000 downloads a week. Equally exciting on the Feeling Good podcasts. In November, we were up to 40,000 downloads for the month of November, almost doubled from October. And so that's on the upswing as well. And then on the website, we're getting about 40,000 hits per month. And then when I write the Feeling Good blogs as opposed to the Feeling Good podcasts, or whatever I publish on the website goes out to about 5,000, 6,000, 7,000 people a day too. So the numbers are increasing. We want to ask all of you if you enjoy the Sunday broadcast or the Feeling Good podcast or the website, www.feelinggood.com, to tell your friends about it and try to spread the word so we can enjoy some of this presumed social media buzz and stuff. I think if Trump has millions of followers, we deserve at least a few thousand more. But at any rate, I got some questions. And hello, Jaime, and hello, David Mitchell, and Fabiola, and John. 91 was the first year John says that he read my books as well. So it's kind of building up. But I've been getting tons of questions via email, and I've been printing them out. I just grabbed a few here at random. Here's one I'll read. I won't give the last names of the people. No, this, we don't need that one. Hi, Dr. Burns. I've recently discovered your book and podcasts. My daughter has done some research and thought your book would help me. I started reading your book, and I was intrigued that you mentioned XYZ University and Dr. XYZ, as I live in a particular city. I won't mention those identifiers just to protect the identity of the person who wrote. I immediately Googled Dr. X and found a YouTube video of her giving a presentation on the connection between alcohol and anxiety. Being a reformed alcoholic, I thought this maybe is what's behind my anxiety and worry, so I reached out to her with an email. She returned my email within minutes and said that the university was conducting a cognitive therapy study in conjunction with the University of ABC. After an initial phone interview and then going through a 2-hour interview with an assessor, probably a psychologist or something, it was revealed the following week that I had GAD, that's generalized anxiety disorder. I was then accepted into a 12-week program for the treatment of GAD, or generalized anxiety disorder. But now I'm a little confused after listening to your latest podcast. And we had a recent podcast, Feeling Good podcast, on the cure for excessive worrying. And you said, Dr. Burns, that GAD, generalized anxiety disorder, is not a true diagnosis. Thanks for any thoughts you have on this. I've laid your book aside for now and will take part in the study, but continue to listen to your podcasts. Thanks to you and Fabrice. Well, thank you very much for that. I'll put an X on here, so I won't answer this one again, knowing I've already answered it. I'll try to explain that a little bit more. It's I think an extremely exciting issue that you raised here is, that we have this thing created by the American Psychiatric Association, and I am a psychiatrist, so I guess I can. It's okay for me to be a little bit on the critical side sometimes. It's called the Diagnostic and Statistical Manual of Mental Disorders. And there are hundreds of so-called diagnoses, like mental disorders in there. So generalized anxiety disorder is one of the most common psychiatric diagnoses, and it just refers to the problem of excessive worrying. Or another common one is social anxiety disorder, where that's just a fancy name for shyness. And then if you're depressed a lot, you could be diagnosed with major depressive disorder. Or if you've been chronically depressed, you could be diagnosed with dysthymic disorder. Everything is seen as a series of disorders that you can have or not have. Now, my problem with this is that most of these are not brain disorders. They're just symptoms of suffering that human beings have. For example, when I give workshops for mental health professionals, I'll ask, how many of you folks tend to worry about things a good bit? And all the hands go up. 90% of the hands go up. And then I'll ask, how many days of continuous worrying are required to have the mental disorder called generalized anxiety disorder? And no one can remember. And it's so interesting, since that's the most common psychiatric so-called diagnosis, and since we've got 100 people in the audience, or could be 200, and since there's only one criterion for the diagnosis of generalized anxiety disorder, why is it that not a single person in the audience knows how many days are required to get this diagnosis? Well, it's because on midnight of the 6th month of continuous worrying about two things or more days than not, at midnight of that day, you get a diagnosis of generalized anxiety disorder. Let's see what that is. There's 365 days in a year, so you divide that by 2. So it's midnight of the 182nd day of worrying, you have this brain disorder, mental disorder, that you didn't have 5 minutes earlier. Now that's nutty. That's like Alice in Wonderland, or similarly, I ask mental health professionals, how many of you have social anxiety or shyness, public speaking anxiety? All the hands go up. Well, how severe does that have to be before you have a brain disease called social anxiety disorder? Well, the fast answer to that is there's no such thing as generalized anxiety disorder or social anxiety disorder. Shyness exists, public speaking anxiety exists, chronic worrying exists, depression exists, and these things can be treated. And now with some of the new team therapy techniques, often with amazing speed. But they're not mental disorders in the sense that pneumonia is a physical disorder. They're just made up constructs based on symptoms and arbitrary criteria. For major depressive disorder, you have to have 14 days of continuous depression, at least moderate to severe depression. Well, why on midnight of the 14th day do you have something you didn't have an hour earlier? It's a nonsensical construct. Now, there's many reasons this happens. And first, let me say, I am not saying that mental disorders do not exist. There are at least 3 or 4 or 5 true mental disorders. A mental disorder would be schizophrenia, and it's a sad, severe problem that has to do with some kind of brain damage. It's the latest thinking there may be some kind of enzymatic deficiency that has to do with pruning of the connections in the central nervous system that we ordinarily do during adolescence, and without this enzyme, the nerves can't, develop properly and prune themselves properly. I don't know if that's been confirmed, but that's it. If it's not that, it's going to be something like that, and hopefully we'll have a more effective treatment and know the cause of schizophrenia in the future. But the reason that's a true brain disorder is it's caused by tissue damage of some kind, and it's not just a variant of how we all tend to feel. I've had almost everything in the DSM, if you want to look at it that way. When I wrote my book, When Panic Attacks, I realized I'd had like 11 anxiety disorders. I've had, when I was growing up, I had fear of blood, fear of dogs, fear of bees. I've had 5 kinds of social anxiety. I had a panic attack once. I mean, we're human, and we have a lot of different kinds of feelings. And then after the book was published, I thought of 6 more anxiety, so-called disorders that I've had. So that's why I love treating anxiety, because whatever the patient has had, I can say, oh, I've had that too. I know how much that sucks, and I can show you the way out of the woods. But you see, if you've ever taken a statistics course, maybe this is too technical for you, but it's not that advanced. And things exist on what's called a bell-shaped curve. Height, for example, we've got some people over 7 feet tall and some people under 5 feet tall, and most of us are somewhere in between. And if you plot this out statistically, it's like a bell-shaped curve. The shorter and shorter you get, the fewer and fewer percentage of the population is at that level, and the taller and taller you get, the fewer percentage of the population is at that level. If you take some halfway point, that's the mean, and that'll be the top of the bell-shaped curve. And that's the same way with emotions. Some of us have very little social anxiety, some of us have a tremendous amount of social anxiety, and most are somewhere in between. But you can't take a cutoff point and say, oh, the 15% of the population who worry the most have a brain disease that the others don't have. That's just nutty thinking. The most basic error in statistics is to try to transform a continuous variable, such as worrying or shyness, into a dichotomous variable that you could have or not have this so-called disorder. You can have or not have schizophrenia, but you can't have or not have anxiety or sadness or depression, because these are just feelings that we all have. We don't know the cause of any psychiatric disorder or problem. We don't know the cause of anything in the DSM, but the good news is we've got great tools to treat these things, and often now with astonishing and gratifying speed, I should say. Now, why has this happened? Well, I can only give you my my reading of it, my theory about why the DSM is set up in this goofy way. I believe that psychiatry has always been the most dubious field of medicine. Ever since the time of Freud, psychiatrists have been viewed by a large part of the population as quacks, and to my way of thinking, with pretty good reason. And so psychiatry has been struggling for an identity, to become more credible in the eyes of the public. And it is my belief that psychiatrists are now in the phase of, they go through phases. There was the phase of Freudianism, and then that didn't really pan out, all the psychoanalysis, and then they jumped on the field of biological psychiatry, where I started out, where now the thing is, instead of treating everyone with psychoanalysis, we're going to treat everybody with pills. And if you can diagnose people into these so-called medical sounding diagnoses, then we sound more like real doctors. And then we can say to a person, not only do you worry a lot, but you have this brain disease called generalized anxiety disorder. And the patient thinks the doctor knows something, has some special knowledge. Oh, I just thought I worried all the time, but now I've discovered I have this brain disease. This expert told me that. And then the patient thinks, oh, I'm going to need a medication for this. It's probably due to a chemical imbalance in my brain. And the doctor can just prescribe. Now, and doesn't have to learn psychotherapy. And I believe it's very hard to learn skillful psychotherapy. Prescribing a medication is pretty quick and easy, to be honest with you. And I think that's what's behind it. And I know here in California, a doctor can get a lot of money from insurance for just having a 5 or 10 minute psychopharmacology follow-up session, maybe $100, maybe close to $200 for that 5 or 10 minutes. So if you just diagnose people and then give out medications, you can make a tremendous amount of money. You can see 5 people easy in an hour, even 10 people an hour, and be taking in all that dough from insurance. And if that's all you know how to do, then you just give out pills, and fairly decent income comes pouring in. But I think we need a diagnostic and statistical manual for research purposes, for clinical purposes, so we know what we're dealing with. But my solution has been, instead of saying you have or don't have this thing, I've simply created like 40 or 50 little brief, extremely accurate scales, like for depression, for anger, for social anxiety, for suicidal urges, for panic attacks, and patients can just fill them out. How are you feeling at this moment? Each scale, you can fill it out and score it and interpret it in 15 seconds. And then I know exactly how anxious this person is, how depressed this person is. Whatever symptom they have, I can measure it accurately in 15 seconds, and then work to increase that score, to improve how the person feels, to see the anxiety go, say, from 80 out of 100 down to 0 out of 100, or something like that. So we're working to reduce symptoms and to increase joy and self-esteem. But for the most part, I don't see it as curing brain disorder. So that's the long answer. I hope it makes some sense to some of you. If not, I apologize. But it's something that I feel strongly about, because I think that this whole thing of viewing human suffering as a series of brain disorders that you could have or not have, it's goofy, it's not logical, and I don't find it at all helpful. Now, David Mitchell, Dr. Burns, in your opinion, in order to be diagnosed with OCD, you must have obsessions and compulsions, not one or the other. I'd have to go through my easy diagnostic system again and see what are the formal criteria. But generally, individuals with obsessive compulsive disorder will have obsessions, obsessive thoughts that make them very anxious. such as you go to bed and then you think, oh my gosh, I wonder if I left the burners on. And you get very panicky, and so you then give in to that urge. You go and you check the stove, and oh yeah, the burners are off, and then you get back in bed again, and you feel relieved, and then you get to thinking, but how do I know for sure? Maybe when I checked them just now, I didn't check them properly. Maybe I didn't look at them right. And you go in and you check them again, and that checking is called the compulsion. And generally the treatment of OCD involves telling the person, you must stop this compulsive checking. If you want to work with me, that will be required, as well as the 4 other models I use for treating all forms of anxiety: the exposure model, the cognitive model, the hidden emotion model, and the motivational model. But most people with OCD have both components, but I think theoretically, I suppose someone could have an obsessive thoughts without the compulsions. But again, these are kind of technical things. How does the DSM set it up? What are the formal criteria required for the diagnosis? And I get tired of checking out the formal criteria because they're usually, to my way of thinking, pretty goofy. So let's see if we have any other questions here from folks. I have another printed question. We have no other typed in questions, so I'll see about this. Do you have any other thoughts on anything so far here?
I don't know if they can hear me, but I think you're doing a great job.
Oh, okay.
I love the way you explain.
Yeah. Okay, well, here's one that comes from Rob. I don't think Rob is listening right now, but Rob is a tremendous individual. He's kind of a fan. He lives up in the Northeast part of the United States. He's been to at least 2 of my workshops, or at least 3, I would say. And although he's a layperson, he has tremendous compassion, tremendously brilliant fellow, and he always sends me terrific questions. So hi, David. Below is some content for your podcast to consider or to ignore. I trust your judgment. I'm very sensitive to your time commitments. I understand you may not be able to respond, and my feelings won't be hurt if you can't. If I had Epictetus's or Seneca's email, I'd probably reach out to them often too. Those were, by the way, Epictetus and Seneca were early Greek philosophers. I think I turned Rob onto that because a lot of what we call cognitive therapy was well worked out 2,000 years ago by the Greek Stoic philosophers. The whole idea that our thoughts, rather than what's happening to us, create our emotions. And if you want to see some dramatic examples of that, go to my website, www.feelinggood.com, and check out the Feeling Good podcasts, especially the ones where we're doing live therapy. And the live therapy with Marilyn is just a beautiful example of how it's our thoughts rather than the reality of our lives that makes us feel the way we do, because she was recently diagnosed with stage 4 lung cancer and was in a state of panic, severe depression, rage, shame, guilt, and courageously volunteered to be a patient on the Feeling Good podcast with Fabrice Nye, who's the host, and then my dear colleague Matt May, a former student and now an esteemed colleague, a psychiatrist practicing here locally, was my co-therapist. And we helped her identify the thoughts about her diagnosis that were causing these intense feelings. And as is practically always the case, she had all of the 10 cognitive distortions, the all or nothing thinking, the should statements, the self-blame, the emotional reasoning, the labeling, the mental filter. And when she turned those around, she just had a complete elimination of her symptoms. It was very, very heartwarming. But at any rate, Rob continues, but it illustrates, the point I was babbling about is how by changing her thoughts, even with a horrific real event, negative event, she was able to eliminate her negative feelings completely. I mean, it was blow away, and we're very indebted to Marilyn. I hope if you haven't heard those Marilyn broadcasts, there's several of them because we broke the session down into three episodes, something like that. And then about 10 weeks later, she had a metastasis to her ribs, a painful metastasis, and relapsed. And so she came in for a tune-up, and we recorded that and published it as well. And so those are very, very inspirational. And anyway, Rob continues, using my Amazon Prime account, I'm streaming a lot of old episodes of Celebrity Rehab with Dr. Drew Pinsky. It was a reality show where an addiction specialist, Dr. Drew, treats addicts. As you might expect, a lot of the addicts reveal childhood trauma. This often leads to a counselor advising you must forgive your mom, dad, brother for abandoning, beating, or abusing you if you're going to overcome your addiction. Is forgiveness overrated? Is Rob's question. I agree. He says that one can hold a grudge and be consumed by it, but your paradoxical agenda setting showed me the beauty that there can be in anger and that perhaps one should hold on to some of it. I heard the sister of the man who was murdered by O.J. Simpson say, I still despise him, but I'm not letting my hatred for him control my life. Well, this is a great question that you raised, Rob. Your emails, your questions are, in my experience, always very thoughtful and provoke a lot of thoughts when I read them. But I'm kind of getting elderly and cynical, and I guess, and perhaps slightly more uninhibited, saying what I really think. But I think that telling patients, and treatment with buzzwords to me is just kind of fraudulent. It's just kind of junk psychotherapy. This is my own feeling here that I'm saying, to say like you must forgive. It just, I'll just say BS. I'll abbreviate it like that. Telling people, oh, this is what you must do. That's not therapy. That's just codependent, narcissistic throwing advice or throwing your idea of help at people. To me, psychotherapy is a very powerful and it's a collaborative process where, as the therapist, I lead the patient on a journey of discovery to on a path, if they're depressed or anxious, to not only recovery, but what I would say experiencing enlightenment. But any time that I've slipped up and started giving advice to patients and telling patients what to do, that's not therapy. That's just some codependent junk type of thing. And to tell you the truth, not only do I believe it's not terribly helpful, I believe it's not going to be helpful to people. Anyway, there's my point of view for whatever. Here we've got we've got David, and then we've got Barb. Hi, Barb. I haven't talked to you for so long, but I see you on these podcasts, and it's a joy, and I'm grateful. Oh, Barbara. Let's take Barb. Now I'm asked this. I'm not offering this, so I'm just answering a question here. I'm not promoting my own political agenda. Barb says, can you speak on the narcissistic qualities of our president and how that affects his ability to do his job? Does it or does it not? What are your opinions? Well, this is kind of politically sensitive, right, Lisa? I'll tell you the characteristics of what's called narcissistic personality disorder, and then how the man who created the diagnosis, what his opinion was on using that diagnosis for the president, what I think about his assessment. But the criteria for narcissistic personality disorder are thinking that you're you're better than other people, that you're very special. And I don't want to throw stones. Oh yes, I do want to throw stones, but I shouldn't throw stones because I have a tendency toward being narcissistic myself, and my wife has gently pointed out that causes a lot of trouble. So I've been trying to fight to do my best to get over that, but it's still a bit of a thorn in the flesh. But the person with narcissistic personality disorder thinks I'm great, I'm better than other people. And so you can ask yourself, does Trump have this tendency? I think I heard him say just recently that he considers himself the greatest person in the world now. I believe I heard that on TV. Don't quote me, but he you can ask yourself, does he have this idea he's some kind of a great person? Secondly, someone who is narcissistic, another criterion is that they're low on empathy. They don't see things through the eyes of others. It's all about me, all about my agenda. And so you could ask yourself, does he have this characteristic? Is he promoting his own agenda, or does he have compassion and ability to see through the eyes of people who are different from him or who disagree with him? A third criterion, and I'm not reading from DSM, this is just from memory, is that people who have a narcissistic personality disorder, or again, narcissistic tendencies, let's say, because I don't want to, again, call it a brain disease you could have or not have. It's just personality traits is what we're talking about, is the inability to receive criticism, the need to not only defend yourselves, but to lash out and hurt and punish anyone who would criticize you or disagree with you. And you can ask yourself, does Donald Trump do that? Let's see, what are some of the other characteristics? You're feeling that you're better than other people, lacking in empathy and compassion, promotion exclusively of your own agenda, the need to punish anyone who disagrees with you or counters you, and then in its most extreme form, it's called malignant narcissism, and that you see in leaders like Saddam Hussein, who then go to the next step of killing people who disagree with you, murdering people, and that type of thing. Now, narcissism, like anything else, is a two-edged sword. When I was a psychiatric resident, I was doing research on brain chemistry, and I had this idea, this is going to be the greatest paper in the world. I was kind of in competition with a group from the National Institute of Mental Health, and I thought their research was done incorrectly. And I wanted to prove that they were wrong. And it was like on a roller coaster, because one day I said, oh my gosh, this is going to be the greatest paper ever published. And then something would go wrong, and then I'd go into hell thinking, oh gosh, I blew it, this is no good. It was like being on a roller coaster. But that idea that I was going to defeat them and prove them wrong really was motivating, this idea that somehow I was going to be at a higher level. And then for that paper, I eventually won the top award in the world, in a worldwide competition for research on neurochemistry, on brain chemistry, and I beat the group from the National Institute of Mental Health. And you can see with Trump too, his narcissism, his grandiosity, his massive ambition has in fact brought him a tremendous amount of achievement. So it's kind of a two-edged sword. But then the very thing that propels you to the front also creates enemies. And I have discovered in my own life that when I'm acting like I'm better than others and start criticizing other schools of therapy, which I have a tendency to do, and I feel so clever when I'm doing it, it turns people off and hurts their feelings. And that when I can be humble and warm and real with people and vulnerable, that's when the magic happens. So the fellow from the American Psychiatric Association who wrote the diagnostic criteria for narcissistic personality disorder said, aha, he doesn't have one of the criteria required for this diagnosis, and that's that it has to not be working for you. And since it's working for Trump, he says we can't diagnose him with that because he's being very successful. And I found that, to tell you the truth, to be not a reasonable criterion. That's another, to me, one of the goofy things in the DSM. It would be like saying, if you have pneumonia, you don't really have pneumonia. We can't diagnose it unless it's upsetting to you. It seems to me people have these narcissistic tendencies, or they don't. And whether it's working for you or not, I mean, that's of importance, but it has nothing to do with whether or not these tendencies exist. And so from my point of view, you know, someone with those tendencies fulfills the criteria for the diagnosis if you want to make the diagnosis. And the idea that you're only allowed to diagnose personality disorders when they're not working for a person, to me, that's more Alice in Wonderland kind of thinking that's inherent in the DSM. So that's as direct as I can be. When I've given workshops and I make cutting comments toward Donald Trump because I find his policies and actions for my value system just profoundly offensive and dangerous and frightening. I don't like to see our country drifting in a direction of more dictatorial, more intolerance for people of different races and religions. In my Tuesday group at Stanford, we have people of all ethnicities. We've got people from all over the world, all religions, Islamic, Christian, atheist, Jewish, you know, Asian, Hong Kong, and it's a gift to find this ethnic diversity a thing of beauty, a thing of joy, and I'm just saddened and frightened by the direction of that our country's moving in, and based on hatred, and so many people seem to want this kind of hatred, and I find it, you know, profoundly disturbing, and I've stopped making snide comments about Donald Trump. But instead, I've taken to speaking my heart, and that seems to work better. And I kind of hope people from whatever pulpit you have will stand up, like the fellow, that millionaire, putting the ads on TV, that he's a clear and present danger, and we've got to notice what's going on and try to move in a different direction. That would be my own personal belief, for better or worse. Let's see here about John. We also, Mitchell, do you think panic attacks just come out of the blue, or are they thought related? No, David, I believe that panic attacks never come out of the blue. Like all forms of anxiety, they come out of a human context, and that's my hidden emotion model, which you can hear about on the Feeling Good podcast. People who are having panic attacks, it's usually, or any form of anxiety, it could be OCD as well. You see this hidden emotion phenomenon, or generalized anxiety, or it's almost always going on. There's something that the person's not telling you that's upsetting to them, and it's generally because they're too nice. They're angry with someone, and they believe they're not supposed to be angry, so they have a panic attack. An example of that would be, for years I was the shrink for the University of Pennsylvania Law School, and the dean would send students to me who had come to the dean of students wanting to drop out of law school due to almost always panic attacks in classes. And what they would say is, oh, I know when I take the final exams, this is like first year law students, they would say, oh, I I'm going to panic when I take the exam, and I won't be able to remember anything, and I can't concentrate. And also, the law school was a kind of adversarial place where they taught the patients through this hostile Socratic questioning. So when the professor calls on you, he starts asking you questions and makes a monkey out of you, and it's supposed to kind of harden them and prepare them for courtroom work and things like this, and then they would be having panic attacks in classes and wanting to drop out of law school. And what it turned out, and I think I treated 30 of these students, it turned out that 29 of them had this hidden emotion phenomenon, that they had been, like, say, first in their college class at Harvard, but they didn't know what they wanted to do after that. So somebody said, "Oh, well, go to law school. That's a cool deal." Or maybe the father wanted them to be an attorney. The father was an attorney, but they themselves had never said, "I want to be an attorney." And so what was really going on was that all of them, once I taught them how to manage the panic attacks or the test anxiety, but under the surface, in 29 of these cases, what was really going on is that they didn't want to be in law school, but because they were very nice, they felt like they weren't allowed not to want to be in law school. So they would generate these symptoms. So instead of saying, "I want to drop out of law school," they could say, "Oh, I have to drop out of law school because I'm having this medical problem called panic attacks, and so I dropped out for health reasons." So they didn't have to say to Daddy, "I don't want to be a lawyer. I don't like this model in the Penn Law School of wealthy Wall Street attorneys. I don't want to spend my life like that. This is not what I want with my life." That was what was going on most of the time. And interestingly, in all of those cases, they decided not to drop out of law school, but instead to stay in law school and use law in a way that they would like to in their life, and to give up on this, being a New York, Wall Street money guy. One fellow decided he wanted to move to Israel after he graduated and do Israeli-Palestinian law, negotiations over the peace issue. Another one said that he wanted to move to Los Angeles and represent as an agent movie stars or athletes, and that was exciting to him. And another fellow said that he wanted to move to Nebraska or Iowa and to the Midwest, in a small town where they had cornfields and just small-time people, kind of like on the Andy Griffith show on TV, and just do divorce law or just business law, just work for people in a small town, maybe sit on his porch with the moonlight in the evening. And, he was just yearning for that kind of life. And once they said, "Here's what I want to do with my life," suddenly the panic attacks or the test anxiety disappeared. Now, I used other cognitive techniques as well to treat the symptoms, but the hidden emotion model was a key to it. And I see that with all forms of anxiety, and it's a beautiful model, because not only does this excessive niceness model have a lot of healing capacity, but it shows us why people develop anxiety when they develop it. And I could give you examples of this with patients with OCD, with panic attacks, with phobias, with people go to doctors with medical complaints that don't amount to anything, and they keep thinking they're going to die of cancer or this or that symptom that turns out not to be real. Almost every time this hidden emotion model is going on. And when they bring that thing that they're not dealing with to conscious awareness, which is something in the here and now, it's not something buried in the past, it's just some issue in their life that they're not owning up to because they think they're not supposed to feel the way they feel. And when you bring this to conscious awareness, express those feelings, solve the problem, typically you see a dramatic improvement, if not a complete elimination of symptoms. Let's see. Here this John is saying, "I'm a fan of cognitive psychology. I'm also a creative person, a musician, Intuitively, it seems there should be some synergy between the two. And he's saying, is there any crossover between directed exercises which help resolve problems for ourselves and non-directed exercises, non-directed writing like journaling? Gosh, this is above my pay grade. I'm sorry, I don't grasp your problem, John. I do know that when I'm working as a therapist, I'm working in a highly structured, systematic way. Like, I don't want my patients to do non-specific journaling, because in my experience, it's not very helpful. I want them to fill out a step-by-step daily mood log. What's the situation? What are your emotions? What are your negative thoughts? What are the distortions in them? Because that procedure has a lot of high-powered, high-speed healing potential. But at the same time, I'm very spontaneous as a therapist. I integrate total spontaneity, sometimes goofiness. Sometimes I just blurt out goofy things during therapy sessions, and we laugh, and even that can have a tremendous healing potential. And at the same time, I'm very structured and systematic, and so sometimes you have to integrate opposites. That's the best I can come up with there. Let's see where we're at. Let's see. Oh, but at the same time, coming back to your question, David Mitchell, the panic attacks, though, are always thought related. The person with the panic attack is telling themselves something that's absolutely untrue. Like, you may be having the thought, I'm about to go crazy. That will trigger panic attacks in a lot of people. Or the most common one is, I'm about to have a heart attack and die, or I'm going to suffocate. And people believe they get these symptoms. They're generally hyperventilating, and they get dizzy, or get tightness in the chest, or tingling of the skin, and then they misinterpret these physical sensations, say, oh my gosh, I feel strange, I must be on the verge of insanity, or I must be about to die of a heart attack, or some such thing. And these thoughts are just, contain all of the cognitive distortions. You're just telling yourself things that are blatantly false. And the moment you realize that those thoughts are false, by doing an experiment to test them, in that very moment, usually the panic attack will disappear. Like, if you think I've shown a video in conferences repeatedly of a woman who, during her panic attacks, thought that she was about to die of a heart attack, and she was having multiple panic attacks every week, and she'd been treated for 10 years unsuccessfully with drugs and psychotherapy, and running to the emergency room and running to the cardiologist, and they kept reassuring her that her heart was fine, and that would reassure her for a day or two until she'd get another panic attack. But the intervention that cured her, and you can read about it in my book, When Panic Attacks, was to just I induced a panic attack in the office, and I had her hyperventilate and told her, imagine that you're about to die of a heart attack, and she became totally sobbing, totally convinced she was about to die. And then I persuaded her to stand up and do strenuous aerobic exercises. And after several minutes of doing this reluctantly, thinking she'd die at any moment, it dawned on her that, if she was having a heart attack, she couldn't possibly be doing these strenuous jumping jacks, and her panic turned into laughter and relief. And in that instant, she really was her first really recovery from 10 years of horrific suffering. So the cognitive part does play a role, but even in her case, the hidden emotion model that I described earlier was a powerful piece of it as well. Let's see. Hi, David. Any experience using team therapy for sex therapy? Yes, we're going to do that live on next week's broadcast to boost the audience. No, I'm just being my ridiculous self here. I have a non-orgasmic woman client, and she's frustrated about it, that could use some tips with. Now, she also has a problem of shooting on herself for her non-orgasmic sex with her boyfriend. Yes, I would say it would definitely be be a piece of that, Alexandra. When we have a problem, we often double our trouble by giving ourselves these should statements and beating up on ourselves and creating frustration and anger and depression and feelings of inadequacy. And the team therapy can be tremendously helpful there. There could also be a relationship conflict. So some of the interpersonal tools, like in my book, Feeling Good Together, could be a part of it. And then finally, when I was a medical student, I read the Masters and Johnson's work for people with sexual disorders, the sensate focus technique, having, for example, the woman can guide the partner's hand over her body in just the way she likes to be touched, but they're instructed they're not allowed to have sex. They're just to do this and for the relaxation, the excitement. And then if anxiety comes up, what I've actually done is have them have a clipboard with a daily mood log there, and then she can write down the thoughts are making her anxious, and they can talk about that and use that as a way of developing greater intimacy if that's what they want. Of course, if there's an underlying relationship conflict, that would have to be addressed as well. And it may be that she doesn't want to get closer to this particular man due to feelings of unexpressed anger or whatever. So there's a lot of potential causes there, but definitely this would be a part of it, the cognitive therapy and the self-acceptance and to learning to be more compassionate with one's self. And Tomorrow says something is very disheartening, but I didn't get what. Barb says, thank you for your honesty, Dr. Burns. Well, thank you for your great question, Barb. I couldn't have done it without you. And I can remember, our dialogues in the past with great affection and clarity, and just so great to see you again. And let's see where we're at now. 3:58. We've got to do something, a short one here. That just Phil, a closing comment. Hi, Dr. David. Thank you so much for your insight and experience. I think the hidden emotion technique is so cool and really explains anxiety in a nutshell. So, thank you so much for that. The Tyann has asked us to do a call to action here, and sadly neither Lisa nor I is savvy enough to know how that's supposed to work, but I think the idea is that if you have ways of telling your friends about these Sunday broadcasts from 3 to 4 California time every Sunday, unless I'm out of town traveling, which happens occasionally, that to tell them to join in. Also, and I don't know if you send them an email or send them the link to these broadcasts. Also, if you invite your friends and colleagues to go to my website, www.feelinggood.com. Feeling Good is one word with 2 G's in it. There's tremendous free resources there for therapists and patients alike, not the least of which is my weekly Feeling Good podcast with Dr. Fabrice Nye. They're also published on iTunes. We're publishing them now on YouTube and a lot of outlets, but you can see all of them there on my website. You can dial back and look. We've got about 60 published so far, and there's other resources for you as well. Can you think of anything else to promote?
Okay, everyone. For those of you who joined us late or who are still on from the very beginning of our broadcast, I'd like to say thank you for joining us. And I think I speak for all your viewers and readers in thanking you, David, for the vast contributions you've made to psychiatry. And I know in working with my clients that many of those people are alive today because of the book Feeling Good. So, and I just also want to thank you for all your hard work in marketing. We couldn't do it without you. And I want to tell your viewers today that things are happening so quickly that, David is making such strides in getting out his word out there about Team CBT and the high-speed therapy that can relieve depression, we know, in 2 hours. I mean, that's unheard of, and that's without medication. So let's continue to work together and getting the word out there.
Let's read Victoria's comment here as a goodbye.
Okay, well, let's see. Hi, Dr. Burns. I am in a Facebook group for social anxiety, and I recommend your books to literally everyone. You helped me recover from severe depression. I am the #1 fan from afar.
Okay, thank you, Victoria.
So I'm going to give the earphones back to David, and also just wanted to say one more thing. We're going to have people on with David to have wonderful conversations about, cutting edge questions, and I'm just here as a guinea pig today.
Yeah, well, I don't know how far we'll be able to go unless we get this technical thing worked out to where I can dialogue. If we can see how to get 2 of us talking to you at the same time. Fabrice today said I need to get a mixer or something like that, and we probably need that for our Feeling Good podcast too. But we'll do what we can. I love you all. Really appreciate your joining in. Have a great week, and see you next same time, same station next week. So bye bye.